actually what it says in there. And this is not something that we just came up with or whatever. Some of the classes we might be doing might seem off the wall, but it's hours that you have to have specifically to fill in the blocks. Paramedics, you get an hour in this specific block, and EMTs, you'll get 30 minutes. It's going to be an hour's worth, but that other 30 minutes, you're not going to lose it. We'll just move it down to something else. There's another category for the EMTs, so you'll have 30 that you have to have required, and then 30 somewhere else. So you'll get everything for it. You're just going to define professionalism. It's the skill, good judgment, and polite behavior that is expected from a person who is trained to do a job well. Y'all have all been trained to do a job well. You do a good job. Just some of the key words that you might see that kind of that go towards being professional. You got patient, compassion, listen, ethical, honesty. As we go through some of the slides, you're going to see a lot of this information popping back up. Fayette County in '83 was kind of brought, all the volunteer departments were brought together kind of under one umbrella, so it would actually be Fayette County Fire and Emergency Services instead of individual fire districts. The director was Chief Smith. One of his things is he wanted to raise professionalism up. It was going from a bunch of small, there was 7 stations, but it was 6 departments. 5 and 6 was kind of the same little department. Wanted to bring it all together and actually raise the professional level up. A lot of people, you'll hear the argument, especially when we start talking about uniforms and all, if you're having an emergency, you don't really care what the person looks like. You'd be surprised. It does make a difference. That Lieutenant Callahan, one of his, I think it was his last ex-wife's husband, whatever it is, that he lives down the street from him. He has a lot of medical problems. Coweta will pull up, and they'll have 2 trucks, an ambulance, and an engine, and everybody will be dressed different. And it's usually ratty looking. And they might be top-notch, know what they're doing, but as soon as he sees them coming in like that, they don't know what the hell they're doing. They look bad. And it's just the opposite. Up at my place in the mountains, it's all volunteer. That every time you see them, they're actually in full uniform. And that, I mean, all pressed neat and all that. And it's like, man, they really know what they're doing. They probably don't have a clue, but they look like it. How many times do you really do stuff on calls? If you look at all the calls you do. Really, you're not doing, a lot of times all you're doing is holding hands and all that. They're going to see that presentation. You could BS them probably, and the majority of the patients, by looking nice and saying the right things. We used to do the little forms they could fill out, tell how good you did. We used to send them out to the stations. That was a lot of the stuff you saw. Oh, they look so good, all this. And I know he didn't do nothing for them. It was just the way he presented himself. A lot of the EMS, that's what it is. We get a lot of BS calls. All right, there's different things that influence behaviors. Big one here is generational. What's professional to an 80-year-old, what's professional to an 18-year-old? One way to look at that, you're 18, aren't you? One way to look at that is just think about church. If an 80-year-old man goes to church, what is he going to be wearing? Suit, tie, going to be dressed real nice. What about an 18-year-old most of the time? Shorts, t-shirts, maybe flip-flops. So, I mean, that's a huge difference. And so we've got to kind of balance it out. We've got to keep the professional levels pretty high to make sure that we cover all the ones. The younger one's not going to care if you're dressed up a little bit more, but the older one, there's a good chance that they might care if you're not. Another one's regional. Think about the different parts of the country. Just 3 major areas. How do they act in New York? How do they act in California? And how do we act here? It's just the region that you're out, you're brought out completely different. You're California, you're probably going to be real liberal. You're going to be doing, things a lot different. Up north, you're going to be an asshole. And so, it's just going to be the different areas you're from. So we've got to kind of tone it down and have a kind of a culture in the department that's kind of the same that'll be able to take care of all these people. Something that makes me think of that, does anybody remember the old guy from Bun Pest Control? I don't know if he still comes around or not. That he comes in the station, every third word's a cuss word, everything else. But you talk to his other customers, and they think he's gold. They'll tell them when they call, you will send him, or I won't do the contract anymore. Depends on who he's with, where he goes, that he adjusts his behavior to be what that person considers professional. Family background. We all come from different backgrounds. We were raised different. If I walked in my house, the house I grew up in wearing a hat, my mom would snatch it off my head, cut it up, throw it away. She was brought up, you do not wear a hat inside, period. And different people are brought up different. And experience. Coming in new to the department, You start seeing how the culture is and what the professional level is, and the more experience you get, the more you kind of assimilate to that. All right, there's 11 characteristics of professional behavior that the National Registry, the training group, has come up with. That really is 10 characteristics that you can find anytime you Google professional behavior. They just add one to it. First one's going to be integrity. Do we need to have integrity? The firm adherence to a code of especially moral values or incorruptible. Think we need that? Consistently honest. You got to make sure you're always telling the truth so somebody believes you. A big one here. Trusted with other people's property. We're going in these people's houses. We don't need to be carrying anything out that's not ours. And if you think about it, and we'll get into some of this a little bit later too, but if you go into this little grandma's house, that you're looking at her property, you've got all of her information, you've got stuff. I guarantee you 99% of them, if you ask them for a credit card, they'll hand you their credit card. They trust you that much, and so we're trusted. We got to make sure that we keep that integrity up and we're not taking advantage of it. Trusted with confidential information. If you've got the PCR pulled up at the station, somebody comes in, you need to minimize it. If you're in the office where they can't see it, that's one thing, but if you're out in the open where they can see it, that's actually a HIPAA violation. You don't want people seeing your medical history if you have anything, so make sure that we don't see theirs. Same thing on the counter. If you're sorting mail, just don't lay the reports out on the counter where everybody can see them. Make sure they're covered up. It's not easily accessible. A big one for the officers on FirePoint. Only got one in here now. FirePoint. If you log in under a lieutenant or other, when you got that logged in, if you get up and move, log it off, because if you don't, somebody comes in, hits personnel tab, and they got every single person in here's social security number. That's my big one. I've tried to get that taken off of there, and somehow I managed to get part of my numbers off, but it's not officially off. Everybody's social security number's in there. So that's something you don't want out there. Make sure you have complete and accurate documentation. I'll get into the other part in a minute. Make sure that you're actually documenting what's going on. That doesn't happen here. Some of you's worked with privates before. How many times have you seen somebody riding in the back, sitting there playing on their phone, doing whatever for the whole transport, but then you get to the hospital and they were God, they saved this patient, they did all this stuff, and they've got 10 sets of vitals and all this. Make sure that you're actually documenting what you do. Don't BS it. The quality of being honest and fair. Next one's empathy. We got to be all warm and fuzzy. It's the feeling that you understand and share another person's experiences and emotions. The ability to share someone else's feelings. Got to show compassion for others, even though it's the scumbag at 1 in the morning that's a drug seeker that wants to go to the hospital. They're a customer. We don't want to be up. We don't want to be dealing with it. That's our job. Got to be compassionate to them. Respond appropriately to the emotional response of patients and family members. If you go to a house that a family member passed away sometime during the night, that patient is obviously dead, cold, got dependent lividity, that rigor mortis is set in, family sees you not working it, that they might get emotional. Their thing to the initial stages of grief might be to yell, scream, and all that. You got to deal with that in the appropriate way, that they're not attacking you. It's just that's the way they deal with it. You got to try to take care of that. Demonstrate respect for others. Big one on this one that's come up pretty much every time is, especially with officers, that you have to respect that rank. You don't have to respect that person, but you have to show respect for that rank. You might not be able to stand them, think they're a total idiot, but you have to respect that rank. I'll do that one in there for you. I know how you are with me. So, demonstrating a calm, compassionate, and helpful demeanor. Everybody can think of that person that does not do that. What happens if that particular person is your partner? What happens when that person gets on scene and starts getting all hyper and panicky and all that? What happens if he's your partner What are you going to start doing? It's a good chance you're going to follow that lead. Now you've got one or you've got both of the people on scene doing that, working on the patient. What's the family going to think when they see that? So you got to think about it. Be supportive and reassuring to others. The next one is self-motivation. You need to be motivated to do or achieve something because of one's own enthusiasm or interest without needing pressure from others. Taking initiative to complete assignments, taking initiative to improve and or correct behavior, taking on and following through on tasks without constant supervision, and showing enthusiasm for learning and improvement. Y'all are doing that today. Y'all all volunteered to come to in-service, so you're showing all that great enthusiasm. Consistently striving for excellence in all aspects of patient care and professional activities. Y'all do that. Accepting constructive feedback in a positive manner. Who in here is type A personality? How well do you take? Type A, this is hard for type A. They don't want somebody to tell them
I'm learning.
This is not right or whatever. Even if you present it in the right way, it's a hard one. It's a hard one to do. They have a real hard time with that. But you need to be able to do that and try to correct it so that you're providing a better service. Take advantage of learning opportunities. I wish on all the different classes we taught, I wish we could do it in this format where we were doing it on duty, everybody could come, but with the way the manpower is and all that, it doesn't work. You know, we've tried, I think it was with the pumper class, that we put it over about 5 weeks just to make it easier for the ones working part-time. It wasn't crammed all into 1 week. You know, to help some people out doing that, we might try a couple other different formats just to see how it works. You know, we don't have any say-so on you being able to get off and being able to come to this stuff. Appearance and personal hygiene. Just going to pass out, and I'll be taking these back up. House rules, and it's just the appearance policy. We're just going to run through this. This isn't something we're going to go through line by line. But if you look at the front page, a little over halfway down, we're talking about being professional. There's a document in place that has that on there about the professional standards. Let's see. Of course, y'all are all maintaining all your current stuff, staying professional, following rules and regulations. You're dressing people appropriately. You're not taking, or your department business takes priority over personal business. Let's see. Not falsifying documents. Cell phones, if the cell phones come on, you know, hopefully they're going to be on vibrate when you're on calls, but you're not going to be sitting there in the middle of a call, your phone rings and answering it, the station. But if you're in classes or whatever, going out to eat, if they give you a discount, they give you a discount. If they don't say anything about it. We've had people in the past that would actually go in and tell them, hey, the cops get it, why don't we? Or, you know, normally we get a discount, why didn't we get it? And there was one, the last group asked me to say, even though there's only two of these left, there's something in here about respecting other people's property. It would stay out their refrigerator and quit stealing their food. Wasn't it y'all that took the picture with the hoods on, or that wasn't y'all?
No, that was Station 3D shift.
Okay. I'd heard it was one of them. Are they the ones that put the gun lock on the door?
We're the ones with the lock. Captain Sergeant come by nowadays.
All right, go back to the personal appearance standards. They wanted us to touch on some of this. Hair, remember on your hair, it can't be worn below your collar. Can't go below the bottom of your ear. It needs to be neat and clean. Brad, you can't wear beads in your hair. Keith, you can't have dreadlocks. No facial hair, you can't have the stuff here or whatever. Mustaches, that policy is in the process of being reviewed. That for right now, it's still the corner of the mouth, but somebody on the first day said it was being reviewed. Chief Bartlett agreed, said it is being reviewed right now. So I don't know what they're looking at changing, but there might be some changes to that coming out. On the sideburns, they're not supposed to go more than halfway across the ear. Scott, you can't wear that hot pink fingernail polish anymore. If you wear necklaces, it needs to be inside your shirt. No earrings. If you do have any body piercings, think about it. You know, I don't want to know about it or know where they are or anything else, but is it a safety hazard? Is it something, if you were doing your job, that something that get hung up? The story on that is there was a guy, we called him Krusty, his name was Rusty, but he was a stripper in his past life. But he'd been here maybe a week. He didn't have a uniform yet or anything. We had just gotten AEDs for all the trucks. Channel 2, Channel 5, or whoever wanted to come down and film a thing on it. The hospital just had opened. So he's going to be the patient. They're filming and they do kind of work, you know, showing how the AED works and all. He's the patient. They pull his shirt up. He's got 2 big hoops in his nipples. And so that didn't go over too good. Just so y'all know, we're recording. Unless I'm standing right next to you, you don't have to worry about anything picking up, so you can answer. Tattoos. Said if they're visible, they can't be offensive, and the chief decides if they're offensive. Uniforms, it's all or none. When you leave the station, if you've got your county t-shirt on, you need to have your top shirt on over it. That my recommendation on that is don't take your uniforms home, especially the ones that's got the little kids at home that you've got 2 working on, what, 6? And and then the thing is you don't know what you get on your uniforms at work. That you could get body fluids. If you've been at the burn building, if you've been at a regular fire, you could get all the carcinogens in your uniform. You've got washers, dryers in the stations. You've got, I don't want to say ample room. You can't put them in your lockers really, unless you're at 3. But it should be enough room that you can shove all your stuff in there. Keep it at the station. That way you're not worrying about it. You don't have to worry about mixing it in with your kids' clothes or anything else at your house. Same thing, kind of moving on to something else, is with your turnout gear. Keep your turnout gear clean. We do some burns here, and 6 weeks or 4 weeks later, we do another burn or another in-service, and we see people coming in that still got the same stuff on their turnout gear. One thing is that material gets into the fibers and it degrades the turnout gear. But another is the same thing, is that you got the carcinogens in there. Don't let your kids wear your gear. You see pictures on Facebook, pretty regular, that somebody took the kid to the station, got the helmet on, got the uniform on, or the turnout gear. That stuff, the kids can get cancer from that. We have a higher incident of skin cancer, especially right across here, than the general population. Is because on our helmets, the helmets are not getting washed. That sweatband's not getting washed. It absorbs that soot, that smoke, all this carcinogens. As you sweat, the pores open up and it allows it to get in there and get inside, so it causes more skin cancer. There's an initiative out, and I can't remember the name of it, but it's wash your Nomex hood every Sunday you work. So you're washing it every 3 weeks. If you catch a fire, wash it after that, but keep it washed every 3 weeks also, just to help keep the stuff out of it. And I can't remember, there's some numbers on there that prostate, there's skin, prostate, and I want to say there was a third one that it's actually doing, but it's all just because the gear's not getting cleaned. Something as simple as you got the machine at the station, or you have access to the machine, that throw it in there, wash it, is clean, good to go. Good personal hygiene. B shift, a bunch of them yelled out somebody's name on their shift, so they wasn't scared to say who it was on their shift that stunk. But one thing, if you had a brush fire, and they did. But it's one thing if you've had a brush fire, you got all sweaty, nasty, or whatever, and you're going to go back and clean. But you've got people that's going to come in every shift that's going to smell like that. Don't be embarrassed. Don't be shy, especially officers. Say something to them. You know, if you were doing it right, we'd go back a bunch of slides and you would be all nice and warm and fuzzy and do it the right way. But we're not. We're in the fire station. Take a friggin' bath. You know, tell them they stink. We've had one on light duty at headquarters that we had to tell them multiple times, take a bath, brush your teeth. You know, it's
You gotta be sensitive.
common sense.
You gotta be sensitive.
We weren't sensitive to that. I mean, he stunk. And the one on Beachville, have your hat by your bed. You know, the one I think about the most is when Billy Martin was here. If he got up in the middle of the night, his hair was doing this. He had to wear a hat. And, you know, if you have that problem, you want to look professional. Make sure that you're covering it up. You need to have, number 5, have self-confidence. Demonstrate the ability to trust personal judgment. Demonstrating an awareness of strengths and limitations. Exercise good personal judgment. Communications. Speaks clearly. Writes legibly. If you've seen my writing, then you know you can't read it. That's my writing's crap. That I have to type everything. But I'm going to kind of go back on the communication part now. PCRs. Anybody in here use the auto generation on that? Nobody in this one? There's not a lot of people left, but we're having problems. We were looking at a PCR the other day that had major problems. Had a 2nd degree type 2, and they never identified that, even though the pulse was 30. But it was like sinus braiding and just all kinds of different terms in the narrative, and each one contradicted each other. But then you look at the narrative as a whole, and they didn't erase any of the things where it'll say this and there'll be none or whatever. They left all that in there. And so you're stumbling through trying to figure out what's going on, and it's got all this garbage in it. Make sure you're documenting. And going back to making sure you're documenting right, and this could have happened, but somebody the strip was there, they were in the 2nd degree type 2, and their rate was 30, 32, something like that. But their blood pressure, they kept saying the blood pressure was 165 over 90 or something. I'm not saying it didn't happen, but what would the likelihood of that be? And it was pretty much, there was 2 blood pressures, but you would get this one and then you'd get this one, and it was more or less just kind of filling in the blank. You got to make sure you're documenting correctly. And another one is, it's got auto spell correct on there. Make sure you're looking at that. When you review reports, I don't know if you correct them or whatever, but if you see stuff, keep a note of it, call that person, make them change it. That way, if they're having to constantly change it, they see where they're going wrong. You know, there's a lot of officers that they just go through and change stuff. And one of the things Chief Holden had beat down hard on was making sure that the right stuff's correct for billing. And it's kind of shifted now. Everybody's more worried about the billing part and missing a lot of the other stuff. And the auto spell correct, they had the balloon festival. And when they would document, okay, they picked them up in the golf cart. Every time they put golf cart in there, the spell correct changed it to GULF, a golf cart. And, you know, it's probably, that's just one thing they caught, but it's probably something that's changed other words that people hadn't picked up on. Listen actively. This one gets me in trouble at home. I make sure that I'm just out of arm's reach, and I'll tell my wife or my daughter to shut their mouth and open their ears, and maybe they'll learn something. I can outrun her, so as long as I'm that arm's distance away, I got a chance. But you can't, if you're constantly sitting there running your mouth, you can't learn anything. It's got to be a two-way street. You got to be able to listen. Usually you learn more by listening, and you can communicate more by listening. Adjust your communication to the various situations. You're going to talk to a 2-year-old different than you're going to talk to a 22-year-old. Well, maybe not a 22-year-old, maybe a 32-year-old. That's just a little thing that they have for the communication cycle. You do the message, you send it on around, make sure that you get the feedback, make sure they understood the message. Number 7 is time management. If you want to be punctual, complete tasks and assignments on time. Something with the time management is being punctual. And this is nothing you have to do. You don't have to be at work until 8 o'clock. But think about the people that you're relieving. You know, you don't have to, I used to come in around 7:15, that if somebody had something they needed to do, a call came out or whatever, take it for them. You know, we've got, and I'm sure there's still some out there that'll park across the street and sit there until 2 minutes till and then pull in because they don't want to do it. You know, think about the other people. Now, if it's there's people out there that'll abuse it too. You've got somebody like that, no, don't do it, let them know. But just kind of be there for the other people. Teamwork. Placing the success of a team above self-interest. Not undermining the team. Helping and supporting other team members. Showing respect for all members of the team. Again, on the officers, you have to respect that position. You don't have to respect that person. But as a team, something to think about. It happens some here. Some of the people here have kind of said some of it's still going on. I know you used to see it a lot in some other organizations. But as an EMT, if you're working with a paramedic, how many times has that paramedic kind of picked on you, told you, hey, you need to do this, whatever, and just kind of give you the crap work? Like I said, it doesn't happen as much here. Some of the ones have said they still get some stuff. But if you think about it, when you run a call, how much more as a medic can you do than that EMT that's riding with you? Majority of the calls, you're the same. You know, it's maybe you're giving a drug, okay, I have to do this one little thing different that they can't do. Or they've hooked up the monitor, maybe I have to, they might be able to read it too. I might have to read it and decide what it is. But really, we're all pretty much equal. We're a team. Everybody needs to work together. If your partner messes up, one of the things I've heard the most, if your partner messes up, don't jump on them in front of the patient. If it's something that's going to cause harm, stop what they're doing, and you do whatever you have to do. Get with them after the call when you're not in front of that person. Be professional about it. If you get onto them in front of that person, then what is your customer going to think? You know, it's, hey, they don't know what they're doing, or, you know, why is he working on me? All right, remaining flexible and open to change. This is something I'm old, having a hard time with. That when we're done, we're going to go next door to the other classroom. We got some video laryngoscopes that pretty much everybody's agreed on the same one, but we're going to let you try it out and see. But before we had the second one, got the first one, did it, this sucks, we don't want any part of this. But now we've got one that's decent to try out. It kind of changed that a little bit. But a lot of times you don't want to change. Communicate with others to resolve problems. Respect. Be polite to others. Not using derogatory or demeaning terms. Even joking around at the station sometimes, somebody acts like they blow it off, but it's really bothering them. You get some of these people that are quiet anyway, and he'll kind of get into some of this in his part, but they could just keep building until they kind of explode. Kind of like when years and years ago, he was out at Station 3, and Chief Holden got thrown through the front door window at Station 3. But he got one of the big guys there mad and kept on picking at him, picked him up, threw him through that plate glass window. Behaving in a manner that brings credit to the profession. Not only are you representing us, but you're representing all fire and EMS. Patient advocacy. The yellow cards we gave out last month, the updated the version. You know, that's something that's actually to be an advocate for the patient. You know, and I would look at it the same way. I remember when they first came out, I looked at it as, this is a bunch of crap. I know when to tell people that they don't need to go here, whatever they're on the version. But that was just an agreement we made to the hospital. We will read this card. I was just as bad as everybody else. When I got to the end of it, I've read you this, but you don't have to pay attention to this. You can go there anyway. Instead of doing that, inform the patient. You know, be there for the patient. Tell them, hey, they're backed up. It might be 6 hours for your scene. Would you like maybe to try Piedmont Noonan? Because Piedmont Noonan, you'll probably be able to get in pretty quick. You know, be there for the patient. You know, you might not want to go, or whatever, it might be the middle of the night. Middle of the day, it'll be a break for you. Drive out there and get a break. Don't let bias interfere. Just because you don't like that person, I don't like you, I'm not going to treat you right. And so you can't do that. Everybody's got to be treated the same. Placing the patient's needs above yourself. Easy one on that one to compare it to. Right now, you go carry a trauma patient downtown, you sat on the scene for 20 minutes, your truck got heated up. You might not be able to turn your air on. You want it warm enough for the patient, you don't want it cool enough for you. You might just have to sweat it out for the whole ride. You're there to take care of that patient. And respecting the confidentiality and dignity. And the last one that they've added in is going to be the careful delivery of service. You want to master and refresh your skills, all that's ongoing education. Performing complete equipment checks. Let's go back to that one. That's another big one we're hitting on. Y'all were kind of in some recent classes. When we had trucks coming out for y'all's class, for recruit class, did y'all notice people having trouble finding stuff on their trucks?
Oh, yeah.
That has been a huge problem. one of the ones that we had the biggest problem with sat in one of the classes, and he never caught on, as even I was staring at him the whole time I was talking about it. We have people, I don't know which truck carries a ram, and so we might ask them to get a ram off their truck. Go through, somebody been on the truck a couple of years, go through every compartment before they realize they don't even carry a ram. And that's happens a bunch, that they don't know where the equipment is. You ask him where something is, he goes right to it, no problem. But on some of these engines, people coming out, and you need to make sure, if you don't know where it's at, or you didn't even know it, you didn't even carry it, you're not checking your truck. Same thing with the ambulances. Need to make sure all the equipment's there and it works. There was one that just came up this week that they were completely out of a particular drug and nobody had turned it in until they needed all of them. And so they turned it all in and they had to fill it, and it's like, why didn't you say anything? And nobody had ever passed it on. Demonstrate careful and safe ambulance operations and following policies, procedures, and protocols. All right, does anybody have any questions?
All right, we're going to do some psychiatric emergencies now. This is a serious subject, but y'all know, those of you who've been in class with me, y'all know we'll have a little fun. However, in this one, we'll have more serious than we'll have fun, but y'all can have fun at my expense. And you'll see where that comes. The very last slide is all about me. It's about suicide, depression, and it's a wonder I haven't killed myself. So y'all will see that on the very last slide, and you'll figure it out. I'll just wait, Jam Hall. It's going to get worse. All right, we're going to talk about some of these psych disorders. We're going to talk about the meds for these disorders. We're going to teach y'all how to do a mental status exam, find out where these patients are. We're going to talk about restraining them, and we're going to talk about the risk factors for suicide and depression. Anxiety disorders, panic attacks. Are panic attacks real?
Yes.
Absolutely, they're real. These people think they're dying. However, people out there claim to have had or having a panic attack and probably aren't? Yeah? Yeah, they're out there too. You got to figure it out. But if you ever seen somebody really having a panic attack, they think they're dying. It's for real. Have some compassion with these folks. I'm not going to call everybody out all the time on throughout this part of it. I don't want to know your particular psychiatric disorder. But who else is obsessive compulsive? Well, I think in this particular case, we probably all are about certain things.
What, is that an OCD?
Yeah.
Oh, yeah.
Now, I'm not saying we're all Jack Nicholson and is as good as it gets, where you got to turn the knob 3 times, turn the light on 18 times, or whatever their number is. But I think for certain things, like me right now, I bought several $1,000s worth of tools for about $500, and I've got them neat and pretty sitting on the wall and sitting in a place, and I'm pretty obsessive and compulsive about beating my kid's butt when he steals them. So I'm being recorded. I'm being nice. Did you notice that? Yeah. Okay. So, yeah.
I have a rug in the base of the toilet, so when I'm feet got me.
Thanks, Jim Hall.
That just happened. That's just a movie about me.
Just happened.
This way you won't have to conversation. Yeah, see?
Okay. Let's move on. We'll talk about meds in just a second. There's a medicine for you for that. PTSD, is that for real?
Yes.
Absolutely. We kind of think of it as a military issue. What do they call it? World War I and World War II? Shell shock. They've gotten a little more sophisticated, done a little more research, and worked a little better. They're probably diagnosing more than they used to. Are there people out there claiming to have PTSD and don't? Absolutely. We had one that went to work for us a while back that was trying to get some benefits for PTSD. I'm not sure he had it. He had issues, but I'm not sure it's PTSD. I just lost my train of thought on where I was going with PTSD.
That
I don't know. Huh? Oh, you just trying to help me? The trigger words to help out the old man? Appreciate the help. Don't think of PTSD just with the military. Everybody in this room has seen things they wish they didn't see. And everybody in this room has got that one call or more that still bothers them today. Hopefully, you'll never have something trigger you that will create you to have some of these problems where you need to be on medication. But if you do, get some help. Call me. I got Nancy Wessellink's number on speed dial. Yeah, I know at one point 85% of the department did. So I hear. So, but if y'all do, get some help. Talk to somebody. Don't be afraid. You know, let's not get it to a point where it's going to affect your life and ruin your life. Phobias. Anybody in the room got a phobia besides me? I'm not going to call you out and ask you to say it unless you just want to. Nobody else, everybody's been too scared except me to say it. Put me in, huh, what?
What? Did that just happen again?
He said grasshoppers. Jam Hall, you're awesome, man.
Gotta perk you up a little bit. This is all right, this is Lieutenant Galloway. Gotta get you happy and laughing.
Oh, okay. I'm being recorded. I have to be semi-professional. But you put me in turnout gear, BA, breathing air, one of them tubes up there. A few years ago, wouldn't bother me a bit. The older I get, the more claustrophobic I get. Somebody said the other day, well, that's just because you're getting older. That's just I don't think so. I think we got some old folks now. It doesn't bother them. Cut. Turn everything off. I'm fixing to whoop some. So, and everybody's probably got something they're afraid of. To what degree? You know, I have to talk myself through that if I ever have to do that again. I know I have to talk myself. There will be a lot of talking that day. Bipolar. Seeing a lot more bipolar folks getting diagnosed now. At some point, y'all have probably worked for someone, or in Eric Williams or my case, been married to someone with mood swings. Hopefully they're not these type, because the bipolar person, they are way up, way manic, and then all of a sudden, boom, they're way depressed. And these swings change very quickly in the bipolar patient. But there are meds that can help these people out. With that said, what's one of the problems with them taking their medications?
When they're mad, they don't want it.
Yeah, when they're up, I don't need it. I'm good. I'm good to go. Or so that this doesn't make me feel good. I don't need to take the medicine. So they don't. Now they got those real huge swings because they're not taking it, and they don't realize when they're all the way down, they should be taking their medicine. If they keep taking it and stay on it, they'll typically can perform out here now. I mean, look at me. No, I'm kidding. I'm not bipolar yet. Depressed people. To make this one real simple, there's something going on in the part of the brain where you have your basic emotions, and it makes you depressed. We're going to talk about the serotonin and norepinephrine and how that affects here in a little bit, and how the medicine works on those to help these depressed people not be depressed. Are there people out there that claim to be depressed, probably aren't depressed? I think we've got a lot of celebrities out on the West Coast right now saying, yeah, I've battled depression all my life and I didn't know it. And I hate to make light of anything, but there are people out there to get attention will do these kind of things. All right, the patient that's psychotic. They could be sitting here right now and they don't have any idea what's going on in this room. They are completely out somewhere else, thinking and away from here. They're really disconnected with what's going on around them. And they'll have these psychotic episodes, and then to the next, they may turn into this agitated delirium. This isn't good. You get real agitated, they get worked up and whatnot, they get aggressive, they start ranting. And oh, let me point out one other thing real quick. Your OCD people, if anybody's OCD about spelling, there's several spelling errors in here. Please point them out to me so I can fix them before we put it on Moodle. It doesn't bother me. Eric Williams berated me enough that I have no feeling about this whatsoever anymore, so I've gotten over that. But there's a spelling error here too, just in case y'all wanted to know. So, but it may be from drug or alcohol abuse. Maybe they had a head injury, and we've seen those people. They got traumatic brain injury, and now they're angry all the time because of that injury, because it's worked on that part of the brain and messed them up. And that's horrible. Have a nice normal life and doing everything normal, and now all of a sudden you're angry at everyone, and over time even your family doesn't want to be around you because you're so angry over stuff. And you can't help that. That part of the brain got injured, and it's created the agitated delirium. These people get so worked up that their body temperature will shoot up. It'll rise. And that's when they start taking their clothes off. They get naked and they run outside. They're doing it for a different reason than you, Jim Hall. I think they had one the other night at a Waffle House in Sandy Springs or something. Some guy got all worked up, got naked, and walked outside of the. And yeah, then everybody in there just turned their waffles back in. I'm not hungry anymore. I'm going to go home. But it may be a medical condition too. They may have rhabdo, or that next one, which somebody said that was misspelled, the neuroleptic malignant syndrome. What that is they're having an allergic reaction to the medicine that they're on. To the psych medicine that they're on. It's not a typical allergic reaction that we see all the time with the swelling or the hives or the difficulty breathing. This affects the brain, and it makes them very agitated if they're having that allergic reaction. We're not going to fix that. That's something somebody else is going to have to fix with doctors and stuff, with checking levels of medicines and those kind of things. But be aware, it could be the medication doing that. They're not normally like this, but they've been put on this medication, and they're reacting to it in a negative way. So watch these people, because they could have cardiac or respiratory problems. All right, we're going to do some medications. Let me do a disclaimer for people watching this on Moodle, because I don't think you can see, I don't know how well you can see the screen with the camera where it is, but pause your screen and go find the slides and coincide with it if you can on your computer right now, so you can see these meds as we talk about them. Anti-anxiety meds. I'm going to show some names up here. I want you guys to tell me the trade name or the regular name of the of the medicine. This one's a benzo. What's the other name for this? For clonazepam?
I will not talk anymore.
Oh no, I want you to, because you're awesome, Woodliffe. Did you get married recently?
Yes, sir.
She work at Chick-fil-A?
No, sir. She works for Rockdale County.
Okay. Klonopin. And when we usually tell who's on what is how fast they tell us the names of the medicine that come up there, so it's okay. Don't be ashamed. We all have issues. What's the other name of this one? Anyone? Anyone? X and X. Or that's what the patient told me. I said, what kind of medicines do you take? You know, X and X. Can X and X? Oh, it's spelled X and X. Okay, I got it now. It's pronounced Xanax, though. Everybody should know that one. No. No. There we go. Ativan. We give this a lot in the hospital. For those of you who don't know, I work at Southern Regional a little bit up in the ghetto. And we have a ton of mental health patients that come through there. And we will give Ativan to calm them down. Central EMS has this particular medicine in their protocol. I wish we did. Yes, sir? You work for Central? Yeah, they do. They do a lot of inter-facility transfers, especially mental health transfers. That's not their primary business, but they do a lot of them. And they do. They give this like candy, I understand. And they probably need to. So we do too up there at the hospital. I wish we had this, and we're going to talk about our protocol here in a little while. All right, stimulants. Anybody know the other name of that one? Ritalin, yeah. Start thinking your ADHD drugs. These kids, not necessarily it's not a mental health issue, but it is stuff going on in their brain. So they stimulate them up, and these kids, to stimulate them, to make them focus is what they're doing. So Ritalin. Amphetamine is all by itself, and everything from here on out is a derivative, or this is added to, or something's added to an amphetamine, because amphetamine speeds you up. Like dextroamphetamine, which is, say it out loud. I'm old. I can't hear. Dexedrine. What's one of the side effects of these drugs? Increased heart rate. What's another one? Dexedrine. What do they sell that for? Over the counter. Yeah, appetite suppressant. It's an appetite suppressant. Y'all may not know this last one. This was one that Andrew was on, my stepson was on, Vyvanse. And it's for him, it was really, the side effect worked with him. It really suppressed his appetite really well. So well that when he put shorts on, it looked like he was riding a chicken. So, okay, y'all have no sense of humor on this shift. None of y'all. Not this morning, not this afternoon. I know your sense of humor, Woodliff. We'll talk about it later when we're not being recorded. So, let's move on to the next one then. Since y'all ain't funny, I'm going to quit telling jokes. To hell with y'all. I'm depressed now. Some of the antidepressants, what they're trying to do on these next few, they're trying to block the serotonin, or not make sure it's not taken up in the body. If you have too much serotonin, you get depressed. That's one of the ways. So think antidepressants that you may have heard on TV, or you've carried these patients, or maybe y'all are on Prozac. That's a big popular one. That's not Cipro. We're not doing antibiotics. Antidepressant. Celexa, that's like a TV commercial there, I think. That's one I hear on TV. Zoloft. There's another big one. A lot of people on Zoloft. Paxil. Got folks on Paxil. There's your Lexapro, Mike. Some will block the norepinephrine. I'm going to pause here just for a second, see if anybody recognizes my spelling error. I forgot the E on the end. What's that one? Antidepressant. Effexor. Heard that on TV. Cymbalta. Yeah. We're not going to talk. I'm being recorded. I'll just move on. All right, antipsychotics. Antipsychotics. Here's the first generation. What's the other name for that? Now think a long time ago, for these real psych patients, what they used to load them up with. And when I'm talking a long time ago, when we were like kids and stuff. Yeah, long time ago. Before y'all were born. Especially you, Potter. Well, look, we're the only ones here. Is anybody else 30 in the room? Did I say close, Jim? Huh? Let me get you a grasshopper just a second. What's the other name for this one? Think a long time ago? No. There's no chloroform up here. We're not putting patients out. Thorazine. was a big one. We used to load them up with Thorazine back in the day. Everybody knows this one. Yep. Everybody knows Haldol. That's just perfenazine. This other one's probably not horribly popular. You might have heard of Prolexin. We've got a whole bunch here that you'll recognize from TVs. The Next Generation. Risperdal. Zyprexa, you probably may have heard of that. Anybody heard of Seroquel? Seen Seroquel? Folks that work in the hospital that get mental patients occasionally will know this one. No, it's an actual medicine. Geodine, you load them up with the, I do this every time. What's one y'all carry? Ativan. Get them started with the Ativan, then you get the Geodine on board to keep them mellow. So this lasts a little bit longer. So we do a lot of that. Abilify, there's a commercial on there about Abilify. And Invega. And Latuda. Yeah. Is that the one they're doing the class action suit now? Yeah, so my TV's on a lot, but I'm not necessarily watching it, and I hear these names, but because they were talking about the commercials the other day. There's one with a little blue guy, and one with a hot chick in a treehouse. I don't know. All right, here's your bipolar meds. Lithium, and I'm surprised, really, y'all didn't bring lithium up earlier. A lot of the groups did. A lot of them apparently like lithium. I'm not sure. Also, your seizure medicines work real well. So the next couple think seizure medicines. You should know this one. Seizure medicine. Depakote. Another seizure medicine. Tegretol. What's the thing about these, though? If they're having episodes, and especially for seizures, but even here, if they're having like psychotic episodes or having their bipolar stuff, but they've been taking their medicine, but they're still having issues. Well, you got to make sure they got to check their levels regularly. So they got to be in the doctor in there, getting blood drawn, see where their level is, because sometimes they got to adjust their level to what's going on with them. So hopefully they're doing that. We talked earlier about the bipolar people not even taking it because they're so happy, everything's great, I don't need my medicine. Well, if their levels get off or things change, they're going to be the same way. So let's get them there. Let's get them to the hospital, get their levels checked, and let's get them back to their doctor and get them regulated. You've probably heard of some of these others, just not quite as popular. All right, we talked about ADHD a little bit. With these kids, we'll talk about some kid stuff here in a little bit more detail in a moment. I don't know any physicians that are prescribing some benzodiazepines for pregnant women. Maybe they're out there, I don't know. But you do have a lot of people right now abusing benzos, and we're going to talk about ketamine. They're abusing ketamine too. It's Special K, according to Lieutenant Gibby, who's got street cred. But if somebody's, a pregnant woman is abusing benzos, hopefully she'll tell you when you ask her. She may not, but try to find out. Because especially if she's getting ready to deliver and you think delivery is imminent and you want to know and you want to be prepared that you may have a floppy baby coming out. And it's just what it says. That baby's flopping all over the place, and usually they don't. They're pretty flaccid and easy to control. But here now you got a wet, bloody baby that's just moving all over the place because of the benzo abuse. So be careful and be prepared for that if you suspect there may be an issue with this female. And sometimes we can tell if they're abusing or not. And the elderly and their medications. And I mean me, I'm elderly. I guess I'm the oldest guy in the room. Nobody wants to disagree. Okay, good. We're already on a ton of meds. We got anyway, so now we go to the shrink, and they give us some kind of other med, and now it's really interacting with us, and we're just not right. And at my age, and we're going to show you some stats here in a few minutes, but my generation, we are very good at suicide. We don't mess around. We decide to do it. We do it. We have the means, we're capable, and we take care of business. So be prepared for that if you have old people like me that you start treating and they may have some mental health issues. We're good at it. Just remember that. And I'll show you the stats here in a minute. All right, mental status exam. Please get your patient's history as best you can. If you can, while you're talking about history, get their family history. Sometimes in the past, they've had relatives very close to them that have the same issues. And these people may not realize that they have that issue. So try to get a family history too. Certain things do get passed from generation to generation. Can we have a patient that is well-dressed, well-groomed, female with makeup on correctly and looking well? Can she or he still be having mental health issues? Oh, absolutely. More often than not, though, we see them when they are at their worst, especially a depressed patient. They're going to be way depressed. They don't care about the way they look or anything. They're going to hair's in disarray, no makeup, clothes are horrible, dirty, may have stayed in them for a few days, and they're carrying everything they own in 3 Kroger sacks with them. So it may be a clue as to how bad they are in their whatever their mental health issue is. Look for them wringing hands. Worried people start wringing their hands. Some will have facial grimaces or facial tics. I'm being recorded. I'd use my normal thing. It's derogatory toward the city, so I'm not going to do it while we're being recorded. Y'all can try to figure it out if you know some folks that work for the city. Watch their mannerisms and actions. If you try to pick up on if they're turning violent or not, and be ready to get out of there. Because who's the most important person on the scene? You. Who's next? Your father. Right. All right, then everybody else. So have an exit strategy if you notice or you pick up that they may be becoming violent. When you're talking to them, in their speech, are they spontaneous? They're talking like you and I are talking, even though I'm doing most of the talking, and y'all are doing some of the answering? Or are they forcing out answers? They're telling you what they think you want to hear, and you can tell it's forced. Are they talking too slow, talking too fast? Are they too loud, too quiet? Bob was here last time I used him. You know, Bob DeMine is kind of loud. It's Bob, okay? We know that Brad Bowman's on the quiet side. If Brad starts getting loud and Bob starts getting quiet, I'm gone. I'm leaving y'all. Because that's not their normal character.
That means Brad's better. You don't need to worry until you hear the John Cena music. John Cena music comes on, it's time to get out of there.
So, and you may not know that. We know those guys' tendencies. But the patient you go to, you don't know. Talk to the family. Hopefully the family will give you some information as to this is way out of character for them. Some other things about their speech when you're assessing them. Can you understand what they're saying? Is it appropriate, what they're saying back to you? Or is it that word salad? They're throwing out words and you can hear them, you can understand them, but they make absolutely no sense. They don't go together, there's not a sentence there. Okay? And in their mood, do they seem depressed? Are they way up, way down? Are they anxious? Or are they angry or agitated? Or the one that scares me, are they scared? And I'll tell you why. It didn't hit me until I was putting this together. And years ago, Andy Taylor's in the fire station, and him and some guy, they bow up to each other, and one says to Andy, I can't remember who it was, but they said to Andy, I ain't scared of you. Andy said, it's a good thing, because scared people do stupid stuff. And that's the truth. You get somebody scared, you know, think about when you get scared or you feel like you're backed in the corner and you're getting scared. What are you going to do? Most of you are going to come out swinging. So you're not going to cower down for the most part. You know, you get a wild animal caged or get them back in the corner, they're going to lash out. So watch out for that scared person. That scares me, scared people. So try to calm them down, calm their fears down, make them comfortable. Their thought process, you can see it in their face, you can see it in their eyes. And where they're talking to you, are they really racing with their thoughts? Are they moving through? Are they hallucinating? And that's just not seeing things that aren't there. The one that worries me is the one that's hearing things that aren't there. Because what are they hearing? I know I can't see what they're seeing, but if they're hearing something, that means somebody that they think somebody's telling them something. What are they going to tell them to do? Because we've heard all that before. Well, such and such told me to kill or do this, and okay. So if they're hearing things, watch these people. All right. Are they having strange sensations? That stuff crawling on them. We've had that patient before. There's stuff crawling all over me. Hey, there's nothing here. It is. I can feel it. Are they being obsessive? Are they hitting on that one thing over and over and over again? It's probably not a concussion if it's a psych patient. They're obsessing over something. Are they suicidal? Are they disconnected? They're just not here. They're not here at all, and you can tell that just by talking to them during this assessment. All right, let's talk about restraining them. Again, y'all the most important, your partner, and then everybody else. Remember, it's for your safety. If you show up on the engine, you don't have a paramedic, let ALS know. You know they're coming. We always send at least one ALS truck with one person at least. Let them know. We may need to chemically restrain this person after we physically restrain them. We're going to talk about how to do that. Here's another typo in case y'all are wondering. This is the only one I thought we had until the other morning when Eric pointed out like 8. But restrain with the help, restrain whomever you can with the help you have. Woodliffe and Potter. Y'all think you can restrain me, the two of y'all?
Don't back down, Potter. Potter's been pumping iron. Scared people with stupid stuff. Scared? I think it's possible. There we go, Woodliffe.
Are you as confident? You better be. You need to be as confident if you're going to go ahead and try. I'm serious. You better be as confident as your partner is so y'all can get the job done. Y'all might could get me, but you're going to know you were in a fight too. But y'all might. Huh? Oh, yeah. All right, I'm going to take you with me. If you're the first one, Will. But with that said, wait for some help if you can. We don't want them hurting themselves, but we need to be able to, the more people we have, supposedly the easier it is. Lieutenant Crandon, when you arrest folks, if they're fighting, you're not by yourself typically though.
Oh, I gotta tell you.
But you're going to have some help. Let me ask you this. How many scraps have you been in with 2 or 3 other guys, cops, that are trying to get one guy down? But do you have problems if you don't coordinate?
Yes.
All right, let me go back to this slide. Let me go back to that slide too. See, I'm ahead of myself here. Shit. We'll talk about it when it comes back up. Let's keep this one going though. If you don't coordinate your, I don't want to say attack, but go together and have a plan, everybody grab a limb. You know, when you get somebody down, of course you're in a little different situation. You're probably 2 or 3 of y'all started fighting, and 3 or 4 more guys want to jump and get a piece of the guy to get him down. But if you're trying to do one thing and somebody grabs the same arm wanting to do something different, y'all aren't going to subdue that guy real easy. You know, you need to work together. Same thing with restraining these people. Have a plan, everybody grab a limb. Hopefully not everybody's on the same limb, and let's get these people down. And we'll move into that in a little bit. But remember, some of these people may not have, they may be having a psych issue also, but they may be having a medical condition, because why do they ultimately go to the hospital? To get medical clearance, right? So they got to get medically cleared before they go to whatever psych facility they're going to be transferred to. How many have fought the patient with low blood sugar before? Oh, yeah? Mm-hmm. Yeah, or the hypoxic patient. I had a little girl whoop my ass one day. She couldn't breathe. She was hypoxic. I'm trying to put the non-rebreather on her, and she's pushing it away, and she's beating on me, and then she's literally grasping for air. She's trying to pull in air, and as I'm putting the thing back on her, she's beating the hell out of me and throwing it away. She doesn't know what she's doing. She's hypoxic. Stroke patient, same way.
Had a guy came out aggressive and fought.
Yeah, that can happen. Bill Stringer's answer to restraints is throw them to the ground face first. And I'm not saying throw, but maybe we need to get them to the ground on their belly to make it a little easier. Have that plan if you have time to do it. But when you do that, or you throw them on the stretcher face first, make sure their face doesn't stay on the mattress and on the sheet. Turn them so they can still breathe. Make sure we protect that airway. Don't let them aspirate if they start puking. Don't put the restraints on so tight that we cut off circulation. So keep monitoring these patients so we don't create a problem. Remember range of motion. Okay? We want to try to restrain that range of motion. How do you typically restrain your patients that are on a stretcher? Typically, what do we do? That's typical for you? Okay. You know, because I see this a ton, especially at the hospital. Of course, they're usually intubated, but you see this. You got their arms by their side, tied to the side of the stretcher. You got feet tied around the ankles and tied to the foot of the stretcher. Which way are these patients going to go? Well, they can sit up. And I'll tell you how to prevent that in just a second. Or they're going to pull themselves down to the foot of the stretcher and go off the end of the stretcher. All right? If you do this, put one arm up here at least. They're not going down that way. And then they're weaker. They can't, especially with my triceps, I can't push up like this as easy as I can pull myself down or push up or push down to sit up. So, and to keep those ones from sitting up, yeah, you got seat belts. Throw a sheet over them, right under their arms, right across their chest. Don't put it on so hard that so tight that they have that anaconda effect where, you know, as they exhale, chest goes in and that thing gets tighter. You don't want anything like that. We still want them to breathe. We just want to keep them on the stretcher and keep control of them so they don't hurt us or themselves. That pregnant female, if you try to restrain her, be real careful. There's another person inside of her. We don't want to mess up her baby. We don't want to have those kind of problems when we're wrestling the pregnant female. Let's talk about females for a second. I forgot to mention it this morning. When you go to restrain a female and you get her down on the ground or on the stretcher, what's probably going to happen with her? Nah, we document real well. We're not going to have a lawsuit. Is she going to quit fighting? Most women don't quit fighting when you get them on the ground. Most men kind of sort of do. We complain a lot more. But a woman starts fighting, she's not going to quit even if she gets to the ground. So be prepared to keep fighting her on the ground. Pediatric patient. Will our restraints work on all pediatric patients? Yeah, I rephrased the question this time. We can get the soft ones pretty small, but not everybody's going to fit into them. Mike Singleton sat on a kid's chest and held his arms down on top of the stretcher all the way to Southern Regional back in the day because the restraints wouldn't work on that kid, and that kid cussed him, 9-year-old kid, and the kid cussed him all the way to Southern Regional, and Mike's sitting there holding his kid down thinking, God don't spit, God don't spit, because we'll get those patients that spit too. So with our pediatric patients, you got to be more careful. I say more careful. We got to be careful with everybody, but that we may not have the restraints that we typically have. So we may have to get more physical and stay physical with them all the way to the hospital. Geriatric patient, me. Be real careful with us. Okay? Give you a geriatric story. Old people here. Y'all will remember. 402 Bates Avenue, does that ring a bell? Used to be Bates Avenue's over in the city off Beauregard. 402 used to be at the end. Now that's gone, and Bates continues on to a subdivision now. But it used to be a house-looking personal care home. We got a call there one night. They said it was a psych patient. I think they were mixing her meds. Intentionally or unintentionally, I don't know. But I think they were mixing her meds. Anyway, she needed to go for evaluation. Well, we had a plan. We all grabbed an extremity. I've still got where she drew blood with her fingernails as she clamped down onto me. And that hurt. So she whipped 4 firemen and 2 cops. She wasn't 80 pounds and 90 years old. She tore us up. So watch out for the elderly. Be real careful with us. Here's your pre-plan. Try to assign people to each limb. Move together. Move quickly. Hopefully the team leader will, as you're doing this, explain to the patient what's going on. It's for their own good in a nice, calm, soothing voice. And that's what I was trying to do until she sunk her fingernails into my arm. And then I screamed like a little girl, and everything else went out the window. We won, but we paid a heavy price for winning. Once you get your restraints on, do not remove them. Until you get to the hospital, and when the nurse says, "Why you got restraints on?" They look calm to me. Take them off, let the nurse fight with them. I'm just kidding, don't do that. I should have said this at the start of this particular part of the lecture. Can we restrain patients? Yes. Absolutely we can. Do we need a doctor's order?
Yes.
It sure would be nice. Can't always get one though. Can you call the hospital and get an order right now?
Yes.
Can you?
Yeah.
Because I'm hearing most of the time what the nurses are going to do is say, follow your protocol and do the best that you can with what you got. Do what you got to do.
I've done it more than once.
I'm not saying they don't.
Yeah, I just call and said, when they said that, I said, I need a doc to give me orders for physical restraint. Her doc, whoever is sitting there.
Yeah.
Go ahead.
You can usually get there and then figure it out. You paint that picture, and when you talk to the doc about the other stuff, and they'll sign for your orders too. We're not going to restrain anybody we don't need to, I don't think. We're pretty good about that. We don't do it willy-nilly. It's a lot of work. But when we need to protect us and them, let's restrain them. In the environment around there, whatever's triggering these people, let's get that trigger out of the room if that's the case, if that's the problem. If they're focusing on the cops and the cops is becoming the problem, can you please step out? But don't let them go far, because they can really help us in restraining. They know how to move people very well when they do. They're trained to do that better than we are. If it's a family member who typically has called you, all they do is care about their family. But right now, they're part of the problem. Let's get them to step out. But we don't want them too far. They may be the one we get the history and information from about why this patient's acting the way they are. Chemical restraints. If they're fighting you and you got them physically restrained, they're still fighting you, let's go ahead and give them a little medicine to help them calm, be a little better. But keep monitoring them when you give them the medicine. This one's a little bit out of order, but it does go along with some of these medicines for conscious sedations and whatnot, and it'll help, even though we carry the benzo we're going to talk about in a minute. But ketamine, there's a lot of people out there abusing ketamine right now. I know in children, I worked at Eggleston, we had a doctor that loved ketamine and Versed for conscious sedations. And I didn't like the ketamine too much. It worked real well, but when you're in the room, especially with a kid, you got to move real slow. You got to be real quiet. You can talk, but you can't do anything sudden or anything loud, because it'll have the ketamine, if that kid could have a reverse effect, and then the kid's through the roof. So you got to be real careful around people that are with that are on ketamine, taking ketamine. All right, what do we carry? I heard something that all went together as a word salad. Versed. Our protocol says Versed. I know we do carry Valium, but our protocol allows you to give Versed. If you can get a doctor's order, that's awesome. Go ahead and get it, but we can give it. It's in a protocol. You got somebody tied down, and you know you got to. They're still fighting. They're tearing up your stuff. They're all over the place. We got to chemically restrain them. Can you get an IV on them? I mean, sometimes, but typically they're going to be, even though they're tied down, they can move enough to where you're going to have a hard time starting an IV on them. So how can you give your Versed? In the nose. Atomize it in the nose, or IM. You got to still, they're probably going to do this when you go to their nose, though. You're going to have somebody still hold their head. And try not, they're going to still move, but try not to break a needle off in their muscle, too. So you're going to still have to hold them down to be able to calm them down. And keep telling them the whole time it's for your own good, but they're probably not going to believe you. They may be so checked out, they just don't know. All right, Suicide depression risk factors. Try to pick up some of these, even though we're not going to have these patients very long, but still watch them. You don't want them to kill themselves in front of you. Hopefully you get them away from anything that they've got. Do they have a history of it? Does they have a family history of it? Have they tried it before? Does everybody that tries to kill themselves want to kill themselves? No. What do we call those people? Yeah, they want attention or they want help. Let's pretend that I say pretend. In our professionalism, with our professionalism, let's say they want help. So we're going to take them to get them help. But you're right, not all of them want to kill themselves. Do they have a history of abuse? And that means, are they being abused or are they abusing alcohol or drugs? And with that being said, if they're being abused, maybe they have an inability to get help. Well, if that's the case, I really want to help these people. They haven't had that chance. Somebody's abusing them. Let's get them some help, and let's get them back on the road to recovery and get them some help. If they're unwilling, the bipolar patient that's supposed to be on their medicine, but they feel so great, they haven't taken it, and now they're so down. You know, in one way, I don't want to feel sorry for them. They're not willing to help themselves, but somebody needs to help them. They don't have an idea what they're doing. We need to get them some help and help them. And watch out for the person who has a history of impulsive behavior. You may not know that when you come right up to them, but maybe the family can tell you that. They act impulsive, because an impulsive act could be suicide. And they may want to take you out with them. So be real careful and keep them away from anything that would facilitate that. And some of these other risk factors, did they just get diagnosed with a serious illness or a disease? Did they just lose a loved one, a job, a bunch of money? Are they in this age group right here? Because these kids are pretty good at this. They get worked up, they get bullied, and we've seen some of that in the news today. They're being bullied, and they go ahead and kill themselves. And in this age, they're having a lot of physical changes. I mean, I realize that not at 24, but that teenager, physical changes going on in the body, and boyfriends and girlfriends, they don't think they're ever going to have another one, so they want to kill themselves. You know, I just want to talk to them and say, I've been married 4 times. If you can believe that, there's hope for you, dude. So here's the other group, my generation, that does it real well. Over 40, we don't mess around. We want to do it, we're going to go ahead and do it. Older gentleman in his 80s, got a diagnosis of cancer, told him he wasn't going to live very long. It's one of my last calls before I came up to headquarters. Or before I got off the ambulance, I guess. Anyway, he came home, walked through his house. On the way through, picked up his gun, went out in the backyard, sat under the tree, and shot himself in the face. Didn't want to deal with the cancer, didn't want to deal with the treatment, didn't want his family to see him go through that and then die anyway. So, old people, make up our mind, you're not going to know it till afterwards anyway. And what was the other thought I was going to do with... Oh, if you suspect to the conclusion it's really not a difficulty in breathing call, this is more of a psych patient, and you start talking to them and getting some information from them, and they're on some medicine, or they were supposed to be on some medicine, they're not taking it, and now they're really depressed, and you suspect they want to commit suicide. It's okay to ask them. Don't say, are you going to commit suicide? Say, do you want to hurt yourself or anyone else? If they say yes, ask them if they have a plan. If they have a plan, let's get them somewhere quickly so they don't have a chance to act that plan out. And hopefully they won't have the ability to do it. I think that's all the next slide. Here it is. We'll go back to that in just a second. So Eric Williams was in triage the other day at the hospital, and that's the scenario that was given, real scenario, real life scenario. And he figured it out. Hey, do you have a plan, or do you want to commit, or do you want to hurt yourself or others? Yes, I do. Do you have a plan? Oh yeah, I have a plan. I'm going to take all this medicine right here. So, wanted to do it, had a plan, and the ability to carry it out. Let's get her to the back. In our case, let's get them to the hospital, and let's separate her from her plan. In her case, it was drugs. hopefully you're not going to go, do you have a plan? And he's got a gun in his waist belt and he takes it out, takes us out and himself. That's not good. So we got to be careful. But it's okay to find out where they stand mentally. And let the hospital know when we transport these people. Hey, they want to do it and they got a plan and they're capable of doing it. Okay, those of you that know me, it's a wonder why I'm still alive. Here's my slide. I'll let you read it. All you got to do is read the top one. And believe it or not, I didn't put in the 5 just to keep myself outside this window. For you don't know, I've been married 4 times. I know you don't know. Everybody else in the room probably should. So it's a wonder I'm still alive, huh, Jim Hall? I don't know why the number 5 is significant, but I swear to God, that's what was in the book. I didn't make it up.
5th time's the charm?
No, the 5th time is not the charm. I'm not doing it again. And I was real careful not to say that the other 3 times. So now I'm saying it. So if y'all should hear that I'm getting married, call me right away, because I'm going to do one of 2 things. Huh?
Was there intervention?
Yeah, we're going to do one of 2 things. Either I'm going to tell you, no, it's a rumor, it's a lie, don't worry about it, it's all good. Or if I say, oh, yeah, then y'all need to get me to Nancy Wesselink or somewhere. Get me some help, because I don't need to be doing it again. So I'm counting on y'all to help a brother out. All right? If you find out they're giving away all their possessions, watch out for them. Did they have any physical or mental stress? That's probably one of the things that they've called you for anyway and has created this trigger for why they are. And again, do they have a plan and ability to carry it out? Let's separate them. Let's help them out from that. All right. Any questions over what you had so far? Comments?
Let's get started so we can get you out. There's another crew just waiting to get in. Got some information for you today on EMD. Fayette County has been doing EMD for years and years and years. The change that is coming is a transfer from priority dispatch to the APCO EMD. And just like you see in the pictures, communications is moving just as fast as everything else in technology. APCO EMD. APCO stands for the Association of Public Safety Communications Officials. The EMD that's in place now is what's called priority dispatch. This is the system that they use. They take the call, there's vital point questions, and that's where they get their information through that, and then they also use this for pre-arrival instructions. Now, we're going to take it one step further. We're going to take it and use the vital point questions, and we're going to establish a priority. You're going to have a priority 1, a priority 2, or a priority 3. And we'll talk more about that in just a second. The vital point questions lead to the priority levels, and they also have pre-arrival instructions. This card that you're looking at is the sample card of what they'll be using next door in 911. Now what you're looking at, the stroke portion from there down is one part of the card. The pre-arrival instructions are for the other problem. So these are half cards is really what they are. But they maintain cards just like they do the computer, just like you in the trucks. You've got the ability to Spillman's down. You look at your pre-plans the old-fashioned way, and you look at your map books the old-fashioned way. So that's what this looks like. The changes I mentioned are in the priority levels, and now we're going to use some of those priority levels for matrix changes with some of the trucks. Priority 1, high priority. Priority 2 is an urgent call, and we'll talk about how all of these relate to response in just a few minutes. And then priority 3 is a low, and in some cases it's a non-urgent. And I've got some good examples. Here's a stroke card. You'll see where it says levels on these cards, you will hear that as priority. Priority will be the word. It'll be a priority 1, priority 2, priority 3. The priorities come from the vital point questions. Anything that's a priority 1, that's a person automatically that they have told when they start asking the questions. Are they conscious or unconscious? If they say unconscious, that goes priority 1 right there. They don't ask any more questions to establish the priorities. If they say they aren't breathing or they're having difficulty breathing, that's a priority 1. They go to other questions and they go to their pre-arrival instructions. You can see on this one for abdominal pain, a priority 2, vomiting coffee ground-like material, bright red bloody stool, upper abdominal pain. They have to ask these questions to get to that point to where they can establish that. The whole time this is going on, they're entering the information. They're entering this information. This is the call notes that you already see on Spillman. The information's already in there. As soon as they determine a priority, the call gets dispatched. Okay, here's some samples of how it's going to work. MVC priority 1 is going to be a medic and an engine. Same thing that we're doing right now. Priority 2 for an MVC, a medic and an engine. Where you're going to see the biggest departure with the priorities are going to be at stations 1, 3, 4, 5, and 11. 6 and 7, 2, and 10 are all still going to be going just like they do on medical calls now. Not going to be any change in that. That's a medical first responder unit. But if you're at any of those medic stations and they tell you it's a priority 1 on an MVC, the engine and the medic's going. If they tell you it's a priority 2, the engine and the medic's going. If they tell you it's a priority 3 on an MVC, that's medic unit only. How many of you have been on the call to where you get this vehicle accident? 54 in McElroy. Really good place. Have wrecks there all the time. You get the call, both trucks run an emergency, you pull up, one's already on a wrecker over here, one's already left. There's one person standing there on the side of the road with SO, and you say, what's the deal? Everything was fine, no complaints, got ready to sign the ticket, and all of a sudden this lady can't raise her arms because her neck hurts now. She's got ticket pain. Have you run that call before? Yeah, absolutely, everybody has. So now when 911 is getting all their vital point questions and all their information, and they key up on the radio, SO calls in and says, 2210, start me a 1052 for neck pain. They're putting in the notes, it's a neck pain. Been on the scene, how many times have you seen in their Spillman notes? Been on the scene 20 minutes. Been on the scene 30 minutes. Any of these that they know have been a length of time like that they're calling back after the fact, you're probably going to get that as a priority 3. That's why we're only sending a medic unit. If it wasn't for that lady having to sign that ticket, you would have never ever been dispatched. So, again, this allows us to set some priorities, keep some trucks off the road emergency, make trucks available for the next call. How many times have you been on a call, the engine gets sent, absolutely nothing to it, you're on the far end of your area, and now you get a cardiac arrest, and you're the closest unit, and you have to go by your station and then keep going. When if you'd have had a priority 3 on this wreck, you wouldn't have ever had to go. And you'd have been sitting there ready to go on the next call. As our call volumes increase, this is one of the ways that we're looking to decrease the overall responses for everybody that's got to go. We've got to come up with a way, this is it, to prioritize. Abdominal pain, you saw that card a few minutes ago. Vital point questions on a priority 1. Okay, abdominal pain, difficulty breathing. That's it, priority 1. Don't even have to ask any more. Get on down, priority 2 on an abdominal pain is medic unit only. There's nothing saying that you get there and you find more than you anticipated. You can't call for the engine, that you can't call for the squad. They can still come on out. It's not an absolute that if they didn't get dispatched, they can't show up. So call them as you need them. Gunshot, this is one of the things that we just left all of them the same. Because if you look, and you'll see the gunshot card in a few minutes, a priority 2, there's only 2 priorities for a gunshot. A priority 2 is shot from elbow to hand or knee to foot. That's a priority 2. But as they're asking questions over there, chances are the reason it was left that way, they'll say, oh, my buddy's been shot. He's shot through the calf. Okay, shot through the calf. Y'all are all EMTs anatomically. Knee to foot, priority 2. If they don't continue asking questions, what if it's knee to foot, through this one, and out the other side? If they don't get that information, then you're going to get there and it's like, oh, this is twice as bad as they told us. So, gunshots, everybody's hyped up on those already. We left gunshots like they are. Now, that's not saying you get a gunshot call, everybody's going, and your follow-up is like, okay, now we're being told that it's an airsoft gun and they're shot in the big toe. Then you and or the battalion have the ability to scale that back in response. Headache. How many of you have run that call? Priority 1 gets an engine and a medic because when they start asking these vital point questions, I've got a headache. It's the worst headache I've ever had in my life. Where have you heard that phrase before? Stroke class. I can't see. I can't see out of one eye. Engine and a medic because that's an emergency. I've had a headache for 3 weeks. Priority 2, medic only. That's the way that the system is going to be set up. We're hoping that we're able to identify some of these and keep some trucks in service. Okay, vital point questions, we talked about them. Establishes the priorities. Conscious or unconscious, breathing, yes or no, difficulty in breathing, all of that's going to go priority 1 immediately. Nature of the complaint, medical or injury. As they have to start asking a few more questions, they move down the list. Is there bleeding? Are there fractures? What's the history? They're not going to get a history like you would get when you get there because they can't take that much time. This is happening very, very quickly. And then further questions based on the follow-up. That's what's going on next door. Here's the gunshot card we talked about again. This is the example of the card. They're going to ask more questions. Is there more than one wound? Is there more than one person injured? Is the blood spurting or pulsing? You see, there's no level 3 response here. There's some cards that there's no level 3 response. One of the cards that came up after we had done this work, these cards have been agreed upon by all 3 departments. We sat down over several months, 2 or 3 times a month, and everybody has agreed these priorities are where they need to be. The only difference in what will happen between the 3 departments is Peachtree City may send more trucks, we may send less. A lot of places throughout the country, and this isn't anything that's just been made up for Fayette County. They've been doing priority dispatch for years. This is just a different product. Places across the country use this to determine BLS versus ALS response, or what medic truck they're using. Some places use this for emergency or non-emergency. That's not us right now. That may be in future years. Right now we're going to use this to dictate our numbers of people that we're sending and the apparatus. But that's what the cards look like. So when you hear discussions or somebody talks about a dispatch card, that's what it is. Here's what you're going to hear. Your tone just like normal. The call's going out, it's going to say Medic 5 allergic reaction. Priority 3, 1313 Mockingbird Lane, Cross Street, Bernard Road. Your status is green and your timeout. Okay. Status green? Yeah. Well, I mean, whatever they're going to put up there, blue, green, indigo, violet, I mean, that's their color of the day. But the thing I want to draw your attention to here is in their priority 3. No engine? Pardon? Is the engine supposed to go to priority 3? No. Priority 3 is probably medic unit only. Because remember, 1 is the worst. 1 is as worst as it gets. We got to make sure that we're very, very meticulous and don't get priority 3 and TAC 3. Well, that's what's missing out of this one, is there's no TAC up here. So you'll get the TAC as well. When you're writing this down, make sure that you don't put down priority 2, TAC 4. Try to make it priority 4, TAC 3, and get confused. Bonus question of the day. Who lives at that address? Pardon? No? Well, yeah. Okay, if you go to TV Land and you watch the Munsters, that's who lives at 1313 Mockingbird Lane. is Herman Munster. And if you don't know who Herman Munster is, please just see us after. But so be very careful in your priorities and tax. Make sure that you're not getting those confused. All right. Okay. Emergency at the top, that's bolded and underlined. That's your true emergencies. Everything we handle is an emergency. Priority 2 is an emergency. It's in red and it's underlined. Priority 3, that's an emergency. We're not going to make a change right now and go to non-emergency on 3s. Can't say that won't happen in the future. That could happen. However, in priority 3, if you get additional Spillman notes between you and the battalion, y'all can make that decision to go non-emergency. Make sure you're getting all of the information. But if they give you a priority 3 headache that you've been on 4 times this week, twice today, and they just want you to come sit and watch a soap opera or something like that, and you know what's going on there, and there's nothing dynamic, then between you and the battalion, y'all agree, and you can make that, you can scale that response down to non-emergency. But right now, everything we handle is on an emergency basis. Keep in mind, 911 is not going to tell you handle it emergency or non-emergency. They're not in that decision-making level. System implementation July 1st. That's why we're here going over it. In the future, you will see APCO fire cards and APCO law enforcement cards. The fire cards will probably go into effect by the 1st of the year. What are we already doing that will have application immediately to the fire cards? Something that we could provide over there and give them the ability to make a decision that we're already doing. Still alarm. So what we do is we provide the vital point questions for them over there, and somebody calls in and says, I got a funny smell in my house. Okay, describe it. Okay, do you see anything? Do you hear anything? Is everything normal? Have you been outside? Have you looked around? At some point in time, you keep asking those vital point questions, and they may say, okay, that's a still alarm. We're not sending a full structural. So what you do is take the decision making from what the battalion is having to do now, and you put it over here next door. And then your alarm goes, you get your same call like you got a few minutes ago, and it goes out as a still alarm. Engine 1, Quint 2, Battalion 7, still alarm for that address, odor of smoke. Give you the same thing. How many of you have been on the call to where you get your dispatch, 2 engines, squad, rescue, and you're going to an outside gas leak? And you get there, and there's a guy standing in his yard looking at his lawnmower and cussing because his lawnmower won't run, and it's dripped a half a teacup full of gasoline. Well, in phoning it in, his wife has called 911, and she's told him it's a gas leak. Is it outside? Oh, sure, he's outside. And they don't get to the point of, it's a lawnmower outside. We give them vital point questions. Natural gas, propane gas, gasoline. What are the circumstances? Then that makes them have the ability to do that better. So, questions?